We are live on the YouTube. We wait for a minute or two and then we'll start the meeting. Let others join.
Sagar need to unmute his phone.
Yeah.
Okay.
Good morning.
Good morning, Sagar.
So it is 4 minutes past 8. Let me start the meeting. So good morning to all. Welcome back to Saturday Club meeting. And today we have a very young interventional cardiologist with us, Dr. Sagar Shah. He's of course an alum of Surat, that is Smimer Medical College at Surat. And he is an interventional cardiologist. He has done his MD internal medicine, DNB, DM Cardiology from Amrita Institute of Medical Sciences, Kochi. And he won the Dr. Haridas Gold Medal for securing top position in cardiology. He has a brilliant academic career with several professional achievements and awards to his credit. At very young age, he has done more than 350 angioplasties and more than 1200 angiograms. And presently is affiliated with Baroda Heart Institute and Research Center and other hospitals in and outside Baroda also. So we look forward to Sagar's very informative talk about a very important topic, and that is update and controversies in coronary interventions. And I'm sure we are going to have a feast of informative talk. So Sagar, the stage is yours now for 40-45 minutes, and then we'll have about 10 minutes of interactive session. So over to you, Sagar.
Thank you, sir. Thank you for the wonderful introduction. I'll just share my screen. Is my screen visible to everyone?
Yes, yes.
So starting the session, today's topic is updates and controversies in interventional cardiology, the good, bad, and the ugly. This title has been given because of the recent controversies, which we will go through in this presentation. So it is always better to start from the historical point of view for interventional cardiology. So here in the first image, we can see that Dr. Frostman is the first one who had inserted a venous catheter. He was a urologist who inserted a Foley's catheter into his cuboidal vein and had gone down to the X-ray department walking in his hospital and taken this X-ray, which was showing catheterization into the right atrium. Then we have Dr. Seldinger, who had introduced techniques for arterial cannulation, and which are also currently used till this date. And here is Dr. Soanes, who had performed the first coronary angiogram, which was by mistake. He had cannulated the right coronary artery, and this is the image which was taken, the first coronary angiogram image. This was done in 1960s, early 1960s. Now coming to the topic of the day, that is angioplasty. So here we can see a very young Dr. Andreas Grutzing, who is a German and has done the first angioplasty in 1977. He has created all these catheters in his home kitchen and had used these on experimentation on animals, and then presented his research data work in the American Cardiology Association. After that, he has performed the first angioplasty in 1977. Here we can see the images having a tight LED stenosis. He has done a balloon dilatation here. And then this is after almost 10 days of the procedure. Here we can see the first angioplasty report, which has been reported as a coronary daughter. So daughter was also an early cardiologist who had done the first peripheral angioplasty. And this is the patient in which the angioplasty has been done. And we can see that even after 10 days, the lesion has remained quite open and has smoothened out over a period of 10 days. So now coming to the topic of the day. So what are we going to talk about? So first of all, I'm going to speak about the physiological assessment of stenosis. Then we are going to proceed and speak about coronary imaging and how do we handle calcified and bifurcation lesions. Then the age-old debate of Cmbg versus PCI. And lastly, on the hemodynamic supports with Impella and Iabp. So first coming to the physiological importance of coronary stenosis. So why is this topic important? Majority of the patients we see in clinical practice are patients who had come for a routine checkup, who had undergone a ECG, echocardiogram, and a TMT, with TMT showing some changes, and the patient has been advised a coronary angiogram. So if the TMT is positive, that means that there is some ischemia being developed while exercise is happening. Patient as such has no symptoms. Patient is completely asymptomatic. And we do a coronary angiogram and we find a lesion which is borderline. So how do we proceed with that lesion? That is the topic. This only pertains to the aspect of stable ischemic heart disease and not an acute ischemic heart disease. So first we go into some physiology. What is the coronary blood flow and how is it determined? So coronary blood flow is dependent on two blood pressures, that is the diastolic blood pressure and the LV end diastolic pressure. And there is a concept which is known as a coronary flow reserve. That is, whenever the demand increases, that is the oxygen demand increases, it is met by an increase of the coronary blood flow and dilation of the microcirculation. At rest, it is about 250 ml per minute, which can increase up to 5 times. And our body has a wonderful mechanism that is by which it auto-regulates in a wide range of pressure. If the pressure drops below this autoregulatory zone, the flow decreases. And even if it goes above, the flow completely stops. So this coronary flow reserve is an important concept we will see ahead. That is, how and when does ischemia result? That is, if there is some microcirculation dysfunction or if there is a stenosis, say if the stenosis is more than 50%, then it is only going to affect in stress situations and not in baseline situations. So the person might not have any symptoms while he is at rest, but if he is undergoing some stress like a TMT, then he might have some symptoms or some ECG changes. At a greater than 90% baseline flow affection, there is affection of the flow at baseline also, and 90% stenosis warrants treatment. So why do we need these physiological tests? We need them because coronary angiogram fails to perfectly detect these lesions quantitatively. Coronary angiogram is a subjective interpretation. That is, if I interpret, I will tell that it is 70%. If some other cardiologist interprets, it might be 80% or it might be 50%. So we need something which is objective and which can be quantified and which is same for everyone. So here comes the picture of the fractional flow reserve. What is a fractional flow reserve? It is a ratio. So the ratio of pressure distal to the lesion and the aortic pressure. So pressure distal to the lesion and the aortic pressure. The normal value is 1. So if there is no lesion, the pressure should be equal distally and in the aorta also. But say if the value is 0.6. So what this means is that there is only 60% of flow what is there in the aorta distally to the stenosis. So we take FFR value at baseline and at a maximal hyperemia. So baseline value might be normal, but if we give a hyperemia, that is, we increase the blood flow artificially by giving medications, that is, increase the heart rate and increase the stress on the heart, then this value might come down and show us that there is some reduction in the coronary blood flow at peak stress levels. So from the long history of research, everyone has found that 0.75 is the cutoff value for which we can say that this lesion is significant and needs treatment. A value of greater than 0.80 indicates an absence of inducible ischemia, and we can specifically say that this lesion can be managed medically. The value of 0.75 to 85, the in-between value, is a controversial value and needs individual attention. So what are the advantages of FFR? So human studies have shown that it does not significantly change with heart rate, blood pressure, or the contractility. It has a high reproducibility. So if I do, some other cardiologist does, the value should be same. That is low intra-individual variability. And unlike the coronary flow reserve, which we had earlier seen, which would depend on gender and CAD risk factors, FFR does not depend on anything like this. And what drug we use is adenosine or maybe nitroglycerin. And there are less side effects with these drugs. So this is basically a screen of the FFR which we use in the cath lab. So this is the red line which we see is the aortic pressure, and the green line which we see is the pressure distal to the vessel, distal to the stenosis, sorry. And then we have taken a ratio, and this is at baseline. Then we give a hyperemic drug such as adenosine, and then we see the difference in the pressures. You can see that the red line is still higher as compared to the green line. So the aortic pressure 98 and the distal mean pressure is 73. So an FFR value of 0.74 indicates that is a significant lesion. So this is one of our cases in which we have done an angiogram, and we see the LAD here has a stenosis quantifying. If I eyeballing, I can say that it is around 50 to 60% lesion. So I'm not sure if it is really affecting the patient, and this is the cause for his or her symptoms. So we have done an FFR here, and we can see that the aortic value, the red graph is showing 98 and the green is 68, and the FFR value is 0.69. This is at maximal hyperemia, that is after giving adenosine. At baseline, the value was above 0.95. So this indicates that this lesion is significant and might be the cause for the patient's symptom. So now coming to the debate, stable ischemic heart disease. Which approach to take? Should we go and stent the patient, or should we manage the patient medically? This has been a topic of controversy since the onset of angioplasty. So I want to specify the importance of stable ischemic heart disease. A patient who has had an MI is not there is no question of debate in those patients. As if a patient has a troponin rise, or if the patient has a reduction in the ejection fraction, or if the patient is having significant ECG changes, then that patient requires an invasive treatment. This stable ischemic heart disease only means patients who never had any MI, that is no rise of troponins, but patient is having angina. This can also include severe angina, that is even for walking for 5 minutes, if the patient has angina, can be included in stable ischemic heart disease. But those symptoms need to be stable, that is over a period of 3 months, that symptoms need to be stable. So I'm going to share some data. I'll be brief in sharing the data because we have a lot of data in this. So this is the FAME2 trial in which they have decided to see the FFR in patients having stable ischemic heart disease, and patients are randomized to invasive procedure and medical management. So OMT means optimal medical management, and PCI means an invasive procedure. So there are two groups, that is PCI plus OMT versus only OMT. So after doing FFR, they have found that urgent revascularization in these patients having a FFR value of less than 0.65 was superior as compared to patients only undergoing optical medical management. So here they have shown that doing a PCI is going to help these patients with stable angina. But then we have such news always coming and going. That is, stents are of no use. They have drugs are always better than stents. So why is this that there is a lot of controversy here? So I'm going to show you a trial which has been published recently. That is the Ischemia trial. Ischemia trial is basically, I'm going to speak a little bit about the funding of this trial and how it was carried out. So this was funded by the National Heart and Lung Foundation of US, and it has been done over multiple countries. India was also one of the largest centers where I work. That hospital was also included, and one another hospital from the state of Kerala has done the highest number of cases for this trial. And what they have done is they have taken patients, they have blinded both the patient as well as the doctor, the treating physician, to the coronary anatomy. So the patient does not know what lesions he or she has. The treating physician is also not going to know what lesions he or she has. What they have done is they have proven the ischemia. How have they proven? They have done it via SPECT imaging, or via echo or a stress echo, or via perfusion imaging. And they have taken patients having significant ischemia, that is more than 10% of the LV, or 3 of the 16 segments, or on CMR more than 12% of the LV. Or they have also included the exercise, that is a TMT. Only patients having significant positive TMT are included. And then they have done a baseline CT-CAG. This CTCAG, the results are not shown to the patient as well as to the treating doctor. They have done this CTCAG just to rule out the left main disease. So if a patient is having a left main disease, then he warrants treatment, and you cannot ethically not treat those patients for your trial. So they have done this to rule out those patients, and then they have randomized the patients to revascularization and medical therapy, and only to medical therapy. And it has a huge sample size of almost 5,000 patients who had been followed for 4 years. So what we see here is, this is the primary outcomes of CV death, MI, and hospitalization for unstable angina, heart failure, and cardiac arrest. So the two graphs, that is the invasive arm, that is the red one, and the blue one, that is the conservative arm, have not shown a significant difference at 4 years. The p-value is only of 0.34. There is, of course, a difference here in both the arms, but that is not statistically significant. Initially, the invasive arm had, up till 1 year, had more incidence of events. And then as we move on, the incidence of events have reduced in the invasive arm, but still not statistically significant. The secondary endpoints also show the same thing with a p-value of 0.21. The invasive arm not showing significant reduction. Now coming to the symptomatic status. So this is not the primary endpoint, but just a side study in which they have seen the symptoms of the patient, how the patient has improved in his or her symptoms. So the blue line is the conservative arm and the red line is the invasive arm. We can see that there is a significant improvement in the symptoms after a invasive procedure. So patients' baseline angina and the angina after invasive procedures have improved significantly. So there are some shortcomings of this study also. We have to look at them because we need to apply them to our clinical practice. The power of the study had been reduced from 8,000 to 5,000 patients. The invasive arm had increased incidence of a peri-procedural MI. So peri-procedural MI means that after doing the PTCA, if the patient has a troponin rise, and it is considered a peri-procedural MI. Usually these patients are not symptomatic. They do not have a lot of problems after a peri-procedural MI. There might be an increase in the troponin, but usually does not warrant treatment. The duration of follow-up is only 4 years. If these two graphs are followed for say a period of 10 years, then we might see a substantial difference between the two. So, but we don't know that yet. Then there is a lack of sham procedure. So now clinical trials have progressed to such a stage where the patients also undergo sham procedures, which was done in the Orbital trial. So here what they do is they take two patients, they are divided into two groups. So for the purpose of blinding, that the patient will not even know that what procedure he has undergone, they will do a sham procedure. That is, they will take the patient to the cath lab, they will make him lie down, they will probably give him some sedatives and keep him there for 30 minutes. They will not do any invasive or not do any PTCAs, maybe just do a check angio and come out. And so the patient at the end of the day does not know if he has undergone a PTCA or if he has not undergone a PTCA. So this is to remove the bias completely. That is, there is zero bias, because it has been shown previously that even if the patient knows that he has undergone a procedure, then he has a higher tendency to report his symptoms, that he's better in his symptoms if we compare it to a patient who is undergoing just medical therapy. And there are other shortcomings, like the core lab evaluation was only from 2012 to 2014. Post 2014, the results were also evaluated in individual centers. And as I told earlier, this does not apply to acute coronary syndromes, highly symptomatic patients, left main stenosis, and an ejection fraction of less than 35. So I'm just going to briefly show the Orbital trial design. I've put this slide because this has a very good trial design, and if someone wants to do trials, this is the ideal way to do it. So what they have done is they have enrolled the patients, they have asked questions about their angina, then they have given medical therapy for 6 weeks. So this is a common phase for all the patients. Then prior to randomizing patients, they have done the stress echo and the stress tests. After that, that patient has undergone a randomized procedure, which is blinded. That is, the doctor doing the procedure knows, but the treating physician does not know what procedure the patient has undergone, whether it is a PCI or a placebo procedure. Then there is a follow-up phase of 6 weeks, and then there is again an assessment with an exercise stress or a exercise test or a stress echo. So here they have done a sham procedure. And we see that there is significant increase in the PCI arm, that is 16.6 seconds. There is improvement in the exercise, but then again, even after doing the sham procedure, it is not statistically significant. There is an increase of 16.6 seconds in the exercise time, but not statistically significant. So this is also the ischemia. This is done by the echo. That is the number of segments have showing improved score after the PCI. This has shown slight improvement, and it is statistically significant. So still we are in a gray zone whether to go ahead with the PCI or not to go ahead with the PCI, because some trials showing some favorable data and the other trials not showing any favorable data. So what is the take-home message from these trials? That is, we obviously know that there is a correlation between ischemia and subsequent death in MI. Revascularization definitely relieves ischemia to a great extent, and it is always better than medical therapy. All trials have proven that the relief from ischemia is better in case of PCI rather than medical therapy. Both the PCI and the Cmbg revascularization strategies are continuously being improved. That is, when this trial was done, the ischemia trial, the number of stents being used, which were second generation stents, were not as much. There have been usage of other stents which are probably of first generation. So, and improved hardware, better surgical techniques are always known to be more effective as compared to the older techniques. Routine revascularization more effectively reduces angina and the need for anti-anginal medication. We all know that these trials are the very ideal situation and probably would not apply to a real life situation. That is, for example, if we see the ischemia trial, they have followed up the patients quite extensively. They have been calling the patients every 3 months and checking whether they have been taking their medicines or not. And they have been home visits, phone calls for this proper therapy, which is not practical in our routine daily practice. Then there is a problem of crossing over. So if, say, a patient has angina on the medical therapy arm, then this patient might insist for a invasive therapy, and that patient might go to the invasive arm. But according to the statistical analysis, these patients are still considered in the medical therapy arm, because this analysis in biostatistic terms is known as an intention to treat analysis. So we do not take the crossed over patients into the other group. And the adherence of guideline directed medical therapy is very difficult and not routinely achieved. So now coming to the topic of coronary imaging. So there are basically two types of coronary imaging which are commonly used. That is intravascular ultrasound, IVUS, and the other one is the OCT. So here is the IVUS, in which an ultrasound probe is introduced into the coronary arteries, and we can see the intravascular ultrasound of these patients. We can easily make out the 3 layers of the vascular bed, that is the adventitia, intima, and the media. The dark layer in between is the media. Inner one, which is highly equilucent, is the intima, and the outer layer is the adventitia. And we can see here that there is a stenosis, the lumen is narrowed, there is a thickening of the media as well as of the intima. And we can see here that this lesion is stented here. We can see the stent struts, that is a highly equilucent areas here. So this is just an example of an IVUS study being done. Here we can see the coronary angiogram, and with very tight lesions here. This is the IVUS showing just a very small luminal area. If we go to the B point, there is the lumen has slightly increased, but still not the ideal size, and C is almost we can say if it is a normal lumen area. So how does this help? We can I'll go to the OCT and then I'll go to the other points. So this is the OCT, in which is a newer technology and with layers of the vascular bed, that is the intima, media, and the adventitia. So these are the lesions which are seen in the OCT. We can see a fibrous cap here. Then there is a fibrous lesion in this photo, and then this is a calcified lesion. The calcified lesion appears irregular with darkened areas. So how does this help? Coronary imaging is a two-dimensional imaging, and we can miss sometimes the eccentric lesions There we can miss vascular remodeling, something which is known as the Glagov phenomenon, in which there can be a positive remodeling and a negative remodeling. Positive remodeling means that there is disease in the vessel, but that has progressed outside. So the luminal narrowing is not there. And the vessel has become thick, the media has become thick, but there is no luminal narrowing. Negative remodeling means that the vessel has not increased in size and there is shifting of the lesion into the lumen, and luminal area is decreased. Then we have the lesion morphology, which can change the treatment which we are going to give the patient. Then there is a reference segment assessment, that is what segment we should land our stents in. And post PTCA also is important to see if your stent is properly expanded or if there are any dissections or not. So here we can see that this is a coronary angiogram. The left main appears normal as a first glance in this view. But if we see the IVUS study here, then we can see that there is significant narrowing of the left main. So from this angle in the two-dimensional view, the left main appears normal. But here we are sure in the IVUS that there is a significant disease of this segment. So this is from the initial studies of the IVUS cases by a renowned doctor known as Topol. And this is the Glagov phenomena which I was talking about. Here we can see that there is an increase in the lesion, but the luminal area is almost the same. This is the negative remodeling in the luminal area, in which the luminal area has been reduced. Then coming to OCT. So how does OCT help? So here in this OCT image, we can see that this is the lesion and the intimal layer over the lesion is very thin. So this is defined that if the lesion cap, that is the thin cap fibroatheroma, is less than 65 micron, then it has very high chances of rupture. If this the width of this cap was more than 200 microns, then we are not worried. We are sure that this lesion is not going to rupture. We might leave it for medical therapy. But in these cases, we need to treat because the cap is very thin and there is a chance of rupture and an acute thrombosis happening in this artery at any point of time. So how do we implement these OCT images in our practice? That is, first we have to see the morphology of the lesion. Then we see the length of the lesion. Based on that, we decide the landing zones. So the landing zone of the stent is always to be in the healthy zone and not into the lesion. Otherwise, there is a stent thrombosis. And then the diameter of the vessel from which we decide the size is of importance. So this is pre-PCI OCT, and post-PCI, after implanting the stent, we need to see if there's any dissection happening. So this is a dissection happening at the stent edge. If the stent is opposed to the edges or not, and if the stent is adequately expanded. So if you do not take these things into consideration, then there is a very high chance that the patient might come back with an acute stent occlusion within a year back to you. So this is of importance, and we cannot make these things out on a routine coronary angiogram. So if we do a OCT, that is always going to help and our results are going to be better. This is the same thing which is happening. So this is a dissection. This is an unopposed stent. So you can see here the gap between the stent struts and the edge or the vessel wall. And this is an under expanded stent. You can see that this is properly expanded and this is under expanded. So we can correct all these factors via using an OCT. So coming to the trials for OCT. So Illumin 1 was a trial which was showing which has compared OCT to angiogram, and we can see that there are changes pre-PCI. Pre-PCI, there's a change in strategy in almost 57% of the cases. So a larger stent has been used in 31, a smaller stent has been used in 31, 8% and 31% of the cases. Stent length also, there is a significant difference being used via an OCT. So this is how we assess. So this is the angiogram, and then we put the catheter down here, and then we do a pullback, and we get these images. Then we decide according to the we measure the end-to-end lumen diameter, and then we select the stent size, and then we implant the stent. So this is another study which is compared OCT and IVUS, which technology to use, and both the results for this, we can see the graph. It has almost been similar, and there is no difference in both these technologies. Both of these technologies have their own advantages and disadvantages, and it depends on the type of the lesion and the type of the patient for which we should use these technologies. So now coming to the controversial aspect of this coronary imaging. how effective it is in real world or in this trial as in Illumin 3. So they have taken 3 arms, that is an OCT guided arm, an IVUS guided arm, and an angio guided arm. The primary endpoints are target lesion failure at 12 months. So what they have done is they have done an re-angiogram at 12 months and seen how many patients have re-stenosis. And of course, MACE, that is major adverse cardiac events happening. So we see here that the OCT guided arm has 2, IVUS has 3.7, and surprisingly, the angio guided arm has the least number of failures at 12 months, that is only 1.4. Even for MACE, we see that the percentage is significantly lesser in the angio guided arm. So they have told that this is an underpowered study, but the OCT and the IVUS guided arm did not show a significant improvement in the strategy as compared to the angio guided arm. So even after all this technology progress and all these multiple modalities which we have, that has not surpassed the angio guided arms as yet. And this is another study in which they have there's a slight difference in which they have done an FFR as well as an OCT. So what they have done is they have taken a patient, they have done the angiogram. If the patient has a significant doubtful lesion, then they have done an FFR for that patient. If the FFR is less than 0.8, then the patient straight away goes for revascularization. If the FFR is not significant, then that patient might go for an OCT, then patient might goes for an OCT, and then they are divided into 2 groups. That is a thin cap fibroatheroma. So if a patient has a TCFA, then the patient is more prone to develop an acute coronary syndrome. So they have stented those patients. And if the patient is not having a thin cap fibroatheroma, then they have left that patient for medical management. And in these patients, it was seen that there is a significant improvement. So if there is a small chance that if we combine all the modalities and if we use the latest technology, then it is always a good thing. We might be able to offer the patient with a better therapy. Then coming to very complex lesions, that is calcified lesions, how we can change these lesions, manage these lesions. So there are 2 technologies used for calcified lesions. One is the Rota Ablation, which has been there for a long time, and the recently introduced one is the intravascular lithotripsy. So I'm going to show you 2 cases for both these things. Rota ablation is basically a diamond-studded burr which is introduced into the coronary arteries and then rotated at very high rotations per minute, and that way it breaks the calcium. Intravascular lithotripsy works in a similar way for the urinary stones which we use. That is, we introduce the balloon which has which releases ultrasonic waves at a high frequency and which helps to break the calcium. So this is the first example of Rota. I'll just play the video. So we can see here that this catheter is introduced in the right coronary artery, and then we have done the Rota ablation here. And I'm just going to show you a very scary video of the patient post Rota ablation. We can see here that there is a perforation happened in the coronary artery and the dye is going into the pericardium. So just to show that we need to do it very carefully, and we cannot afford to be not careful for these patients because it might end up with a death on the table. And this is an intravascular lithotripsy. So this is a very simple procedure to do. Even a new beginner can do this procedure very easily. That is, a balloon is introduced into the lumen of the artery and then inflated. And then there is a small machine which gives the ultrasonic frequency waves. And this is the final result pre-stenting. So the patient had a significant left main disease and an LAD and an LC exhaustive disease, which has improved post this intravascular lithotripsy. So a trial for these patients is a shockwave trial, a disrupt CAD, in which the shockwave coronary IVL system was used, and it has shown to be having a very good performance. This trial has been recently published in 2020. And the surprising part is that the US FDA had till very recently not approved IVL in US, but it is used in India extensively. The cost is a very limiting factor, but I think it is a very good technology and might help in future. Now coming to bifurcation strategies. So till now, bifurcation lesions have been something which anyone would avoid and would send the patient for a surgery. But recently, with progress of technology, there has been advancement in PCI technologies by which you can do bifurcation lesions also. Patients not willing to undergo surgery can undergo a bifurcation PCI. So with these coronary imaging techniques, so what we see here in the third image is an 3D OCT, in which this is the side branch and this is the main vessel, and it has been stented, and we have done a 3D OCT to see how the patient has responded. And then there is a micro CT scan also, which you can do, in which you can see the stents, how they are opposed to the walls and if they are expanded or not properly, and with which we can very precisely do a PCI in this bifurcation lesions. So this latest paper from the European Society of Cardiology shows that gives us guidelines how to do bifurcation lesions. And the point that they have emphasized is that you should not complicate the PCI. That is, if you see a bifurcation lesion, your first strategy, if the side branch has a significant disease or maybe not so significant disease, is to put a single stent and not to use more stents. You just put a single stent into the vessel and then dilate the main vessel, and the side branch should remain open. If the side branch remains open, then you stop the procedure. You take the patient out of the cath lab and do not further proceed with more stents, as to avoid metal in the coronaries. But in unavoidable cases, you can always use technologies which are also available. That is a Q-LOT technology and the DK crush, in which the two stents are used. And this is a complex methodology by which we put two stents. But this is also shown over a period of time that it has shown very good results. So a left main bifurcation PCI can be done by a Q-LOT method. LED D1 or also a left main can be done by a DK crush also. So in DK crush, we put the side branch stent first, then we use a balloon to crush the stent at the ostium of the side branch. Then we recross it, dilate it again, and then we put the main branch stent, and then we dilate both the stents. So then coming to Cmbg versus PCI. So this is an interesting debate which has been going on from time immemorial. From 1967 when the first Cmbg was done, and 1977 when the first PCI was done. And after that, there have been trials and trials showing which is better or which is not. So this is just a brief overview from 1988 to 2008, what all trials have been done. It has not been proven by any of these trials that which has been superior or which is inferior. There have been trials which have been showing that Cmbg is better. There are trials which have been shown that PCI is better. And these trials are designed so intricately that it is very difficult to implement these trials in our clinical practice. And also the fact that the technology keeps evolving, that the surgical technologies keep becoming better and better. The PCI technologies keep becoming better and better. And they have to keep doing newer trials to prove that this newer technology is becoming better and it might show good results. So coming to the latest trials from this debate, that is the Syntex, Pre-Combat, Noble, and Excel. So all these trials, you can see here, I'm just going to briefly show you that none of the p-values have been significant in these three trials. That is the Syntex, Pre-Combat, and the Excel trial. Only in this MACE trial, that is Noble trial, in which was published in 2020, it has shown that there is a significant improvement with Cmbg rather than with PCI for left main cases. So the primary outcomes in this was in favor of Cmbg, but in rest of these other three trials, it has almost been equal. I'm going to speak a little bit more about the Excel trial because this has been a matter of controversy and in a big way in the European Society. So BBC did a whole program for 1 hour criticizing the Excel trial and how there has been inconsistencies in the data and the data published. So there was a fallout between the surgeons and the cardiologists who had undertaken this trial. That is midway through the trial and just prior to the publication of results, the surgeons withdrew their support and told that there has been manipulation and we will not support. So these are the headlines which were given in BBC. So what were the controversies in this Excel trial? So first of all, the first controversy was the definition of Peri-Procedural Mi. So I have spoken about this earlier also. What is peri-procedural MI is post-procedure, an increase in the troponin level is defined as a peri-procedural MI. So there have been a lot of definitions, and the different societies define this peri-procedural MI differently. So obviously after CABG surgery, there is bound to be a troponin rise because the patient is undergoing manipulation of the cardiac tissue and the patient is undergoing such an extensive surgery that there is bound to be a troponin rise. But this might not be not translate into a lot of problems at a later stage, but still it is considered to be an MI. So what the surgeons said that the peri-procedural MI definition has been changed midway to increase the primary endpoint in cases for surgery as compared to PCI. And the second point is all-cause mortality as a secondary endpoint. All-cause mortality is the hardest endpoint to achieve in any trial. And it usually has to be a primary endpoint because it is something which you want to achieve via whatever treatment you are doing to reduce the all-cause mortality. But in this, they have taken it as a secondary endpoint, and which a lot of people told that it is not correct. Repeat revascularizations have also been kept in the secondary endpoints, and hence there was a matter of controversy because CABG has a lesser number of repeat revascularization. The hazard ratio shifts in favor of CABG after 30 days. So during the first 30 days post-surgery, the hazard ratio is more in comparison in CABG cases as compared to PCI cases. And the CABG group is more heterogeneous. There was no blinding in this trial, so the CABG group was very heterogeneous, and more sicker patients were taken in the CABG group. So these are the points of contention, and that is why the surgeons withdrew their support. And there is always a question of the funding. So which company is funding the trial? There are very few trials being funded by the government societies. India, obviously, there are none. But in US also, there are very few trials which are funded by US government-backed institutions. So 79% of are funded by private industries and 8% are funded by non-profit organizations. So you can see that how these trials can distort data. Then coming to the last topic for the presentation, that is hemodynamic support during a PCI. So I'm going to start with a case which we recently had. There was a 53-year-old male having an extensive anterior wall MI. He echo-wise had an EF of 30%, severe LV dysfunction, blood pressures of 80/50 on inotropic support. The patient is in cardiogenic shock and has been referred to us for management of ACS and cardiogenic shock. We took the patient for a procedure with the initial pressures being 50/30. So at a pressure of 50/30, you expect the patient to crash just in a few minutes. So what is to be done next? You obviously require some support because even on inotropic supports, these patients are not doing well. So first we have done is we have put an intra-aortic balloon pump. So here you can see the tip of the balloon, and this is the balloon expanded here. And we have supported the patient with an Iabp, and then he has undergone a PTCA. We have opened up his LED. The patient improved and went home, thankfully. So what are the devices which are available to us? So this first one is the Iabp device. The second one is the Impella device. And the third one is the tandem heart device. So effectively in practice, probably in Baroda, we only have the Iabp, which we use extensively. This Impella and this tandem heart are really expensive devices. But Impella is being used extensively during PCI supports in the United States. Tandem heart is something which you can use for a longer period of time because it is introduced through the femoral root. So can it be that simple? Can it? So this is just showing the trials of Iabp and Impella and whether they improve the outcomes in these patients or not. So this is the Iabp Shock 2 trial, after which Iabp use has been reduced significantly. So here we can see that there was one arm of acute myocardial infarction who had undergone an Iabp, and this is the control arm in which these patients were only given inotropic support. There is no difference in these two arms. And this is the IMPRESS trial in which they have compared Iabp and an Impella. And also there is no significant difference between these two arms. So even after we have seen patients improving, but then to prove that on a trial is very difficult, and hence we might not be justified in using these devices at all times. So we have some some of our own data also for Iabp. So we have used Iabp extensively in India. So this is from where I did my residency, Amrita. We have a data of around 106 patients who had undergone an Iabp for acute myocardial infarction. And we have seen that what patients have improved and what patients have worsened. So I'll just show you my results briefly. So this is the outcome, the 30-day survival for patients. 45% of the 45 patients out of the 106 patients have improved. 25 have expired. The rest of the patients had been lost to follow-up. And this is the vessel involvement. The number of patients surviving are all more in cases with Iabp. So what the real world data is showing us might not be true for, and might not be correlating with the trial data. So it is up to the decision of the physician or the treating doctor to decide what to use and what not to use in all the cases. Thank you for the patient listening. And this is just the angiogram of the patient, the first angioplasty done, that is in 80, well, it was done in 77, and this is the repeat angiogram of the same patient, Adolf Bachmann. We can see that the lesion has not progressed and the patient was doing quite well. Thank you.
Thank you, Sagar. That was really very detailed and comprehensive presentation on what is happening in this field. So the house is open for any questions, comments. I see a lot of physicians here, so there may be questions here.
Sagar, is length of the narrowing important in decision?
Yes, sir, definitely.
Cmbg and PCI.
Yes, sir. Length of the narrowing is extremely important. Diffuse disease, extensive disease are usually seen in diabetic patients, and the longer the stent you use, basically, is there are more chances of restenosis happening, and the longer lesions are usually seen in diabetic patients, and these patients are always better treated with a bypass surgery than angioplasty.
Is there a cutoff point?
Not specifically point, but the longest stent which we have in our setup is a 48. The available longest stent is also up to 60 millimeters. So as such, there is no cutoff point. It goes down to the individual choice to send the patient for a Cmbg or to do a angioplasty. There are a lot of other factors also at play. If I might just add a point, that how is the patient's status, what is the patient's age, and how is the other comorbidities of the patient, by which we can decide that the patient will be a better candidate for a Cmbg versus a PCI also.
And you have at Baroda had this intravascular sonography?
Yes, sir. We use it. Okay. We use it, but it is a bit expensive, so cannot use it in all the cases. But definitely, we do use it whenever the patient is motivated and willing.
Do you have OCT?
OCT, we don't have the machine, sir, but whenever required, we can get the company person to get the machine if the patient is willing for the same.
How do you monitor the post-PCI stented patient, symptomatic, after 3-4 years?
So the routine protocol is that if the patient has been doing good for 1 year, we usually shift the patients to antiplatelets and everything. And then if the patient has remained asymptomatic, then there is nothing much we need to do. But if there are doubtful symptoms, then we do advise a stress test like anti-EMT or maybe a dobutamine stress echo, by which we can assess if there are any ischemic changes which are happening. If these changes are happening, then we would advise a re-angiogram, of course.
There is no non-invasive way to test.
There is a CT coronary angiogram which can be done, but it is a non-invasive way, but then you are still exposed to the dye. So until and unless absolutely necessary. And in cases of coronary stents, the results for a CT coronary angiogram are not so great. Post bypass surgery, they are very, very precise and very accurate, but post angioplasty, they are not so accurate. So basically, the clinical assessment and stress test are important.
Do you calculate FFR in almost all patients of stable ischemic lesion?
No, sir, not all patients. So a lot of patients we do are basically a part of the Mayam Amrutam or the Ayushman Bharat Yojana, and these schemes do not allow us to do FFR. So if the patient's insurance covers it, or if the patient is willing to pay an extra, that doing an FFR is almost equivalent to doing an angioplasty. So a lot of patients will not be willing to do the same. Ideally, it should be done for all cases. In borderline cases, that is 50 to 70% of lesions, all cases need a FFR. But if you are having a doubt, then you should always explain the patient that you need a FFR, and we should go ahead and do it. But we don't do it for all patients, to answer your questions.
Sagar, what is your opinion about calcium score, and do you recommend it as a non-invasive procedure for coronary artery disease?
Calcium scoring, sir, can be used, but the people we are using calcium scoring should be very selective. So we cannot use it for all patients, not use it for a very high risk patient, that is diabetic patients, dyslipidemic patients. Their calcium score is going to be high. And we can use it for young patients just coming for a routine checkup or for a cardiac screening. For those patients, we can use calcium scoring. And it has somewhat been a good marker for coronary artery disease, but still not a foolproof marker, because there have been a lot of patients having a calcium score of absolutely lower values, that is between 0 to 50. So the cutoff for calcium score is somewhere around 100 to 400. 100 to 400 is the gray zone. More than 400 is definitive CAD, and less than 100 is definitely no CAD. But then there have been cases in which young patients have plaque rupture. So what I showed in an OCT, that is a thin cap fibroatheroma, that might rupture. That lesion might not have any calcium, and that you might not pick up on calcium scoring and then that patient might present with an ACS. But overall, to quantify the risk for your low risk patients, we can definitely do it, and that is something which you can show to the patient that, see, you have a very low calcium score, so the chances of having a coronary artery disease are very less, even though not nil, but significantly lesser.
So my turn now.
Yes, sir.
What is calcium scoring, by the way?
Sir, so calcium scoring is a form of a imaging technique which is done using a CT scan. So the plain CT is done of the coronary arteries, and as we know that we can easily pick up calcium on a CT scan, and so there is a software which will detect the amount of calcium in the three arteries, that is a left coronary system and the right coronary system, and then it gives the software calculates a score for us. So if the score is very high, then the patient is likely to have a significant amount of a coronary burden, coronary stenosis burden. If the calcium score is very low, then that patient is likely to have pretty much normal arteries. So that is used as a screening tool, basically for low risk patients, to see if they have coronary stenosis or not.
What is the indication for CT angiography?
So CT angiography, sir, recently has come up in a big way with the improvement in CT technologies. CT angiogram has been come up in a big way. You need good machines, at least 128 slice CT scan, and softwares for CT coronary angiogram. These are used for screening of patients coming to the ER with complaints of chest pain, who you feel have not very high risk. So the risk stratification is very important for these cases. If you feel that the patient is diabetic, age is a risk factor, patient has other comorbidities such as diabetes, dyslipidemia, and there is a very high chance that this patient will have acute coronary syndrome, then you should go for an invasive arm. But if a patient is of low risk, say a 40-year-old man coming to you with no risk factors such as diabetes, dyslipidemia, or smoking, no troponin rise, not much of ECG changes, then we can go ahead and do a CT coronary angiogram to rule out coronary artery disease. So CT coronary angiogram is very effective in ruling out a coronary artery stenosis. It might be not very significant in ruling in, that is, it might show a borderline lesion, say about 50-60%. If we do an invasive angiogram, then that's the lesion might be very tight. So for high risk patients, I would not recommend, but for low risk patients, it is a very good way to screen. But the problem in our setups here is that the machines available here are always not so great. The expertise required for CT coronary angiograms is also sometimes not available, because only a few radiologists and a few cardiologists do it. A particular subgroup in which it is very effective is the post-bypass surgery patients, because sometimes during a conventional angiogram, to find the graft sometimes becomes very difficult. So in that subgroup, CT coronary angiogram is very effective. And also for congenital heart diseases, CT coronary angiogram is very effective.
What I see, probably there is an abuse of or misuse of this technology, because a couple of years back when there was a death in the friend circle, all of the pediatricians got their CT angio done. Was it, I mean, asymptomatic patient, is it justified? Just to rule out, like, I am 64, I don't have any symptom, but I want to allay that anxiety that maybe I am having coronary, because there are reports of sudden deaths in doctors. So
Yes,
is it
sir.
justified in getting CT angio for that apprehension?
I would not recommend a CT angio, sir. Probably a calcium score would be a more this thing to calm down the apprehension. If there is a significant calcium scoring, then I would recommend a conventional angiogram rather than a CT angiogram. But just to allay the apprehension, we should not go ahead and do it. We have other better tests like the TMT or maybe other types of stress tests, which can also give equivalently good results. And see, if you do a CT coronary angiogram, if there is a significant lesion, you need to do a conventional angiogram and treat that lesion. So if you are doing a CT, you are taking the dye twice. And CT coronary angiogram requires a large amount of dye to be used. So there are also side effects of CT coronary angiogram. You cannot do a CT coronary angiogram at a heart rate of more than 70. So you need to give IV beta blockers to control these heart rates. You need to bring it in 60s. If you do it at a heart rate of 80, that result is almost always invalid. There are so many artifacts that you cannot interpret the results. So all these are the drawbacks of CT coronary angiogram. But in the recent times, there have been progress in the technology. So the most latest progress is what they do is a CT coronary angiogram FFR. So in that, they do an FFR based on the CT images, which is not come into clinical practice as yet. It is in an experimental stage, but it is a very promising thing which can be done. So if you feel that some patient has a lesion which is doubtful and that patient does not want to undergo a invasive procedure, we can offer that patient a CT FFR. If that is significant, then only we can tell that this is significant, you need to undergo treatment. So there are newer technologies coming, and probably with time, there might be improvement and we might be able to use it more frequently.
So there is a question in the chat box from Dr. Sulin Trivedi. It's regarding evaluation for cardiac or coronary problem beyond 50 years. So are there any protocols, recommendations for screening?
Yes, of course. So this is basically after 40 years. After 40 years, you should have a baseline value of your LDL cholesterol, your diabetic status, and of course the other basic parameters such as the creatinine, LFT, and everything. You should have a baseline echocardiogram, a baseline ECG always. And if you are asymptomatic, you can undergo a stress test also, like a TMT or a stress echo. If the patient is very healthy, then of course undergo a TMT. If the TMT is negative, patient is asymptomatic, there is nothing further to be done. We can monitor that patient over a period of, say, maybe yearly or once in 2 years with a repeat TMT or a repeat echo cardiogram to follow these patients. And if at any point the patient has symptoms, then there is a warrant in evaluating this patient further. Like if the patient has had acute symptoms, then you need to do a troponin. If the patient has had stable angina, then you can repeat a stress echo. If the stress echo and TMT both are negative, but clinically the history is very suggestive, then that patient should undergo a coronary angiogram as well. So in these patients, these type of patients, see if the patient is around 45 years of age, previously no symptoms, ECG echo normal, stress test normal, but the patient is having on and off symptoms. You are not sure whether this patient has a coronary artery disease or these symptoms are due to gastric issues and everything. Then these patients are the correct group to undergo CT coronary angiogram. You don't want to subject the patient to an invasive procedure where you are not sure of finding anything. Then we can tell these patients that you might as well go a CT coronary angiogram to see, because you had some symptoms, we are doubtful of it. We don't want to give you a coronary angiogram, we can do a CT for these patients. So that is where it becomes useful.
So thank you. That answers the question. And it's already, time is up now. So we end this session here. Thank you, Sagar, for a very informative talk, and especially the interactions were very good. So we look forward to some more talks in the future from your side. Thank you for joining Saturday Club group. Thank you all for attending. We'll meet next Saturday again. Thank you all. We end the session.
Thank you, sir.